ಕುಟುಂಬ ವೈದ್ಯರ ಸಂಘ ಮಂಗಳೂರು ಇದರ ಆಶ್ರಯದಲ್ಲಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಹಾಗೂ ಕಾಲೇಜ್ ಆಫ್ ಜನರಲ್ ಪ್ರಾಕ್ಟೀಷನರ್ ರಾಜ್ಯ ಲೆವೆಲ್ನಲ್ಲಿ ನಾವು ಇವತ್ತೀಗ ಈ ಧ್ವಜಾರೋಹಣದ ಸಮಾರಂಭದಲ್ಲಿ ನಾವೆಲ್ಲರೂ ಭಾಗಿಯಾಗಿದ್ದೇವೆ. ಕಾರ್ಯಕ್ರಮದ ಪೂರ್ವದಲ್ಲಿ ಡಾಕ್ಟರ್ ಶೇಖರ್ ಪೂಜಾರಿಯವರು ಅಧ್ಯಕ್ಷರ ಪದಕವನ್ನು ಡಾಕ್ಟರ್ ಅಣ್ಣಯ್ಯ ಕುಳ್ಳಾಲ್ರವರಿಗೆ ಕೊಡಬೇಕು ಅಂತೇಳಿ ಕೇಳಿಕೊಳ್ತೇನೆ. ಇನ್ನು ಇವತ್ತಿನ ನಮ್ಮ ಈ ಸಮಾವೇಶದಲ್ಲಿ ಮುಖ್ಯರಾದಂಥ ನಮ್ಮ ರಾಜ್ಯದ ಮುಂದಿನ ನಿಯೋಜಿತ ಅಧ್ಯಕ್ಷರಾದಂಥ ಡಾಕ್ಟರ್ ಚಿನಿವಾಲ ಇದ್ದಾರೆ, ಡಾಕ್ಟರ್ ಸುಲೋಚನಾ ಮೇಡಮ್ ಇದ್ದಾರೆ, ಅವರ ಮಿಸ್ಸಸ್ಸು, ಮತ್ತು ಇನ್ನು ಡಾಕ್ಟರ್ ಗೀತಾ ದೊಪ್ಪ, ಡಾಕ್ಟರ್ ಹೇಮಲತಾ ಇದ್ದಾರೆ, ಡಾಕ್ಟರ್ ವೀಣಾ ಇದ್ದಾರೆ. ಇನ್ನು ಇವರೆಲ್ಲರ ಇದರಲ್ಲಿ ಗೌರವಾಧ್ಯಕ್ಷರಾದಂಥ ಡಾಕ್ಟರ್ ಸದಾಶಿವ ಪುಳನಾಯರಿದ್ದಾರೆ. ಇನ್ನು ನಮಗೆ ಎಲ್ಲ ನಮ್ಮ ಕುಟುಂಬ ವೈದ್ಯ ಸಂಘದ ಎಲ್ಲ ಮಾಜಿ ಅಧ್ಯಕ್ಷರು, ಯಾರು ಕಾರ್ಯದರ್ಶಿಯವರು ಎಲ್ಲರ ಪ್ರೆಸೆನ್ಸ್ನಲ್ಲಿ ನಾವೀಗ ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಮಾಡ್ತಾ ಇದ್ದೇವೆ. ಇನ್ನೊಂದು ಮುಖ್ಯ ವಿಷಯ ಏನು ಅಂತ ಹೇಳಿದರೆ, ನಮ್ಮ ಈ ಕುಟುಂಬ ವೈದ್ಯರ ಮೊದಲನ ಮಾಜಿ ಅಧ್ಯಕ್ಷರುಗಳು ಹಾಗೂ ಈ ವೈದ್ಯ ಸಂಘವನ್ನು ಉಳಿಸಿದಂಥ ಬೆಳೆಸಿದಂಥ ಡಾಕ್ಟರ್ ಮೋಹನ್ ದಾಸ್ ಭಂಡಾರಿ, ಡಾಕ್ಟರ್ ಅಚ್ಯುತ ಕುಡೂರು, ಡಾಕ್ಟರ್ ಜಯಪ್ರಕಾಶ್ ಖಂಡಿಗೆ ಇವರೆಲ್ಲರ ನೇತೃತ್ವದಲ್ಲಿ ಇವತ್ತೀಗ ನಾವು ಈ ಸಮಾವೇಶವನ್ನು ನೆರವೇರಿಸುವಷ್ಟು ಮಟ್ಟಿಗೆ ನಾವೀಗ ಬಂದದ್ದಾಗಿರುತ್ತದೆ. ಅವರ ಅನುಪಸ್ಥಿತಿಯಲ್ಲಿ ನಾವು ಇದನ್ನು ಮಾಡಬೇಕಾಗಿದೆ. ಆದರೆ ಅವರ ಧರ್ಮಪತ್ನಿಯರು ಬಂದಿದ್ದಾರೆ, ಲಲಿತಾ ಭಂಡಾರಿ ಅವರು. ಯಾವಾಗಲೂ ಡಾಕ್ಟರ್ ಮಿಸ್ಸಸ್, ನಾವು ಡಾಕ್ಟರ್ ಅಂತ ಹೇಳಿದರೆ ತೊಂದರೆ ಇಲ್ಲ, ಅಷ್ಟು ಗೊತ್ತಿರ್ತದೆ ಅವರಿಗೆ. ಅಂದರೆ ಇನ್ನು ಡಾಕ್ಟ್ರು ಹಾಕೊಳ್ಳಿ, ಅದು ವಾಪಸ್ ಡಾಕ್ಟ್ರ್ ಅಂದರೆ ಬಂತಲ್ಲ. ಇನ್ನು ಶಾಂತಿ ಕೊಡುವರವರು, ಇವರ ಮೂವರು ನಾವೀಗ ಇವತ್ತಿನ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಧ್ವಜಾರೋಹಣವನ್ನು ಮಾಡಿ ಈ ಮುಂದಿನ ಸೈಂಟಿಫಿಕ್ ಸೆಷನ್ಸ್ಗಳು ಹಾಗೂ ಉದ್ಘಾಟನಾ ಸಮಾರಂಭ ಬಾಕಿ ಎಲ್ಲ ಇವತ್ತಿನ 6 ಗಂಟೆವರೆಗೆ ನಮ್ಮ ಕಾರ್ಯಕ್ರಮ ನೆರವೇರಲಿಕ್ಕುಂಟು. ಅದಕ್ಕೆ ಎಲ್ಲರೂ ಅವರ ಧ್ವಜಾರೋಹಣ ಮಾಡಿ ನಮಗೆ ಚಾಲನೆಯನ್ನು ಕೊಡಬೇಕು, ಪ್ರೋತ್ಸಾಹಿಸಬೇಕು ಅಂತ ಕೇಳ್ತೇನೆ. ಅದರಿಂದ ಮೊದಲು ಡಾಕ್ಟರ್ ಗೀತಾದಪ್ಪನವರು ಲಲಿತಾ ಮೇಡಮ್ನವರಿಗೆ ಶಾಲು ಹೊದಿಸಿ ಗೌರವಿಸಬೇಕು ಅಂತೇಳಿ ಈ ಮೂಲಕ ಕೇಳ್ಕೊಂಡು.
ಮೇಡಮ್ ಸ್ವಲ್ಪ ಟರ್ನ್ ಆಗಿ
ಡಾಕ್ಟರ್ ಹೇಮಲತಾರವರು ಡಾಕ್ಟರ್ ಅಂತಲೇ ಬರ್ತೇನೆ. ಕುಸುಮ ಖಂಡಿಗೆ ಅವರಿಗೆ
ಮೇಡಮ್,
ಡಾಕ್ಟರ್ ವೀಣಾ ಮೇಡಮ್ ಹೇಳಿಯೋದು. ಇನ್ನು ಧ್ವಜಾರೋಹಣದ ಕಾರ್ಯಕ್ರಮವನ್ನು ಮೂವರು ಸೇರಿ ಒಟ್ಟಿಗೆ ನೆರವೇರಿಸಿಕೊಡಬೇಕು ಅಂತ ಹೇಳಿ ಹೇಳಿಕೊಡುತ್ತೇವೆ.
ಮೊಬೈಲ್ ಇಲ್ಲಿ ನೋಡಿ, ಎಲ್ಲ ಇಲ್ಲಿ ನೋಡಿ ಸರ್.
ನಿಮ್ಮ ಎಲ್ಲ ಸದಸ್ಯರಿಗೂ ಆಫೀಸ್ ಬೇರರ್ಸಿಗೂ ನಮ್ಮ ಧನ್ಯವಾದಗಳು. ನಮ್ಮ 3 ಜನರ ಯಜಮಾನರನ್ನು ಗುರುತಿಸಿ ನಮ್ಮನ್ನು ಇಲ್ಲಿ ಕರೆದಿಸಿ ನಮ್ಮನ್ನು ಸನ್ಮಾನಿಸಿದ್ದಕ್ಕೆ, ನಮಗೊಂದು ಅವಕಾಶ ಕೊಟ್ಟಿದ್ದಕ್ಕೆ ಧನ್ಯವಾದಗಳು. ಮತ್ತು ಈ ಸಂಘ ಇನ್ನು ಮುಂದೆ ಚಂದಕ್ಕೆ ಅವರ ಹೆಸರನ್ನು ಮುಂದುವರಿಯಲಿ ಅಂತ ನಾನು ಹಾರೈಸ್ತೇನೆ.
All of you, namaste. All be sitting straight. A few seconds with the eyes closed. Don't lean on the back chair. We'll start with a small prayer. भद्रं कर्णेभिः शृणुयाम देवाः, भद्रं पश्येमाक्षभिर्यजत्राः, स्थिरैरङ्गैः सुट्टवागुंसस्तनूभिः विषेम देवहितं यदायुः. स्वस्ति न इन्द्रो वृद्धश्रवाः, स्वस्ति न पूषा विश्ववेदाः, स्वस्ति नस्तार्क्ष्यो अरिष्टनेमिः, स्वस्ति नो बृहस्पतिर्ददातु. ದ ಮೀನಿಂಗ್ ಆಫ್ ದ್ಯಾಟ್, ಶುಭವಾದನ್ನು ನಾವು ಕಿವಿಯಿಂದ ಕೇಳೋಣ, ಮಂಗಳಕರವಾದ್ದನ್ನು ನಾವು ನಮ್ಮ ಕಣ್ಣುಗಳಿಂದ ನೋಡೋಣ. ಅಂಗಗಳು ಸ್ಥಿರವಾಗಿ ದೇಹವನ್ನು ಪ್ರಾರ್ಥಿಸುತ್ತಾ ದೇವತೆಗಳು ನಮ್ಮ ನಿಗದಿಪಡಿಸಿದ ಆಯುಷ್ಯವನ್ನು ಚೆನ್ನಾಗಿ ಕಳೆಯೋಣ. ಓಂ ಶಾಂತಿ 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 for the body, mind and soul. You can open your eyes. Probably some of you have already done it. Now, my pleasure to call Dr. Chakrapani, Dr. Sadashipolnaya, Dr. K.R. Kamath, and also Dr. Dr. G.K. Bhatt, Dr. Jesse, and also my co-chairperson, Dr. Hemlata. Please. Jesse here. We are on time. As I feel the moderator's responsibility to set the time and facilitate the whole progress, guide the discussion, address challenges, and also introduce the speakers will be done by Dr. Chakrapani. Session we try to be on time. It's my pleasure to Dr. Chakrapani is well known to all. Like the textbooks of medicine have always been Davidson, Harrison, Hutchison, Nelson. Probably Chakrapani's son should have been there. He is the medical superintendent of KMC. Probably you have heard of Kodandapani, Sri Rama, Treta Yuga. Chakrapani is the Sri Krishna. He doesn't have that Sudarshan anyway, but he is a flutist. With this I hand over the mic. I'll be in the chairperson. Thank you.
Good morning to all of you. It's a very good weather outside and the right time to sit inside on a Sunday and learn a few new things so that it can be applied in our practice. Dr. Jane Bhatt has set the right tone for the discussion with invocating a very nice prayer song where it was highlighted that we should remain healthy, our bones should be healthy, we should be able to continue with our day-to-day living as much as possible as it is destined. That's where osteoporosis is important. With the fragile bones, it's very easy to see someone who has been very active in life, elderly patient. Because of one fracture, they become bedbound, they have bed sores, aspiration pneumonias, and that's why it is a silent killer. It's truly a silent killer. Someone who was very active, productive in life, elderly patient, can succumb to osteoporosis due to secondary complication, but the root cause is osteoporosis. It is a nightmare for orthopedicians. It is a nuisance for general doctors and internists and primary care providers, and misery for the patient and the families. So to discuss all these points, we have a nice panel of doctors. Dr. K.R. Kamath, who is a professor and head of the unit, Government Venlock Hospital, KMC Bangalore, will highlight on the complications of osteoporosis and the causes of the osteoporosis. And the other main group which suffers from osteoporosis are women. And women are more prone for osteoporosis and its complications, and Dr. Jesse Maria D'Souza, obstetrician, gynecologist, and infertility specialist, will be the person who will explain matters relating to women health, especially osteoporosis. And finally, we have got a very important person, because osteoporosis basically is the disease at a primary care level. That's where we have to pick up these cases much earlier, before the bones become fragile. And since it is a silent killer, we need to prevent that killer. We need to prevent the fragile bones, and that's where the role of primary care doctor, general practitioner will be coming to play. And we have Dr. Sadashipolnaya, senior general practitioner from Bangalore, who will tell us about the approach in general practice and handling of these patients. We will be going through a series of questions to discuss this topic. And I request our chairpersons to remind us whenever we are reaching the time limit, so that we can wind up the discussion in time. And to begin with, I'll start with the question to Dr. K.R. Kamath. In case you need some clarification in between, please feel free to interrupt us. We'll be happy to take up questions during the discussion itself instead of waiting till the end, because basically this is a panel discussion. It will be in the form of question and answers. Shall we start? Permission of chairpersons? Yes. Dr. K.R. Kamath, what is osteoporosis? Now, generally it's believed, or it was believed, that it is a disease of the West. We don't have to really bother about that. We believe that our bones are stronger and Western bones, they suffer because of osteoporosis, and it's not a disease that we need to worry about. Is that true? And what is the burden of the disease in Indian context?
Thank you, sir. Good morning to all. A decrease in the bone mass with the decreased density is osteoporosis. The porosity, the holes in the bone increase, and they are more prone for the fractures. It's not a disease of West. It is uniformly all over the world. It is in all ethnicities, all races. Osteoporosis is there, and it is more common amongst the women of white and the Asian races when compared to the blacks. So that's the important thing about osteoporosis. The disease in which the bone becomes fragile and it is more likely to break. And most of the time the hip, the spine, and the collis fracture, and also the proximal humerus, all these areas the bone breaks. So that's why it is so common. Unfolds 1/6 of the population is having this our osteoporosis. Every sixth lady after post-menopause are getting fracture. So in this in the world, it is more than 200 billion to 500 billion fractures occur because of the fragile bones. And the bone formation will be there till 30 years. After that, the bone is a very active tissue. In fact, bone forms and bone rapidly becomes destroyed. So whereas after 40, 0.3% of the per percent the bone will get destroyed. But in postmenopausal period, it is 10 times more. So 30% of the bone mass decreases in that particular 10 years of perimenopausal period. And in males, it is little after that, around 60 to 70 years, same rate of progression of bone destruction. So 30% bone mass decreases in 10 years, which is the cause for fragility. And whatever we take, the destruction or the bone rapid osteoporosis will be happening. In India, every third menopausal every third lady is having osteoporosis, fragile bones. And after 50 years, it is told 50% of the women will have osteoporosis. And men also, after 60 years, have same amount of osteoporosis. There is multiple surveys conducted. Everybody is that osteoporosis is increasing. It is not decreasing. One of the causes for that is our age. Average age of life expectancy is increasing. So the bones are becoming becoming fragile. And that's why today, being the World Osteoporosis Day, it is the best time to discuss about osteoporosis, one of the common condition in general practice. So that's what it is. Once again, every women is suffering from, one out of every, after 50 years, women is suffering from osteoporosis, every second woman. And it is quite, this also other several attributes because of the genetic, gender, and different dietic preferences, all are responsible for fragile bones.
Thank you, Dr. Kamath. He has explained how, as the age advances, bone becomes porous and weak. And generally, patients get confused between calcium and vitamin D and osteoporosis. They equate calcium and vitamin D with strong bone and normal bone. It's not true. If the calcium is deficient, bone becomes softer. If the vitamin D is reduced, bone becomes softer but not fragile. So it produces osteomalacia. So people usually confuse between osteoporosis and osteomalacia. And here the importance is that bone is not a static structure. Dr. Kamath has very much highlighted that point. It's not like a rod. It's not like a rock. It is a very much actively changing structure. There is continuous bone formation, bone destruction. As age advances, the formation comes down, destruction continues. The end result is there is less bone. So when the less bone is there, the bone becomes porous and cavities will be there. That is when it becomes very, very fragile. So the need is to prevent this reduce formation and increase destruction. That will come during the prevention part and treatment part of it. But it is important to remember that the treatment should focus on increasing the formation and decreasing the resorption. That will come later. Dr. Sadashiv Polnayam, who are the subjects at high risk for osteoporosis? Because you will be seeing them in the general practice. And how do you identify the patients in general practice that require further evaluation for osteoporosis? Are there any specific symptoms and signs, or do you go by risk stratification and see which group of patients require further evaluation? Do you wait for the symptoms or not? Dr. Polnai, please.
Good morning to all. So it's a disease, it's a silent killer. Like ischemic heart disease, it does not produce any symptoms in the beginning. But the factor is age, modifiable factors and non-modifiable factors. Modifiable factors, of course, you can do something. Non-modifiable factors, you can't do anything. You cannot change your gene. You cannot prevent aging. So that we have to focus on. Usually it appears above the age of 40. Usually say 50, you can say. There are so many causes, mainly hormonal imbalance. That is one thing. And lifestyle factors, very important. You have to maintain body mass index. So if you are overweight, you have to control the weight. So they are all modifiable factors that you have to concentrate on. And usually we see people limping, only they come to doctors after sustaining fracture. They come out while from the their gait we can make out he is osteoporotic. Who are susceptible? People with sedentary life. That is very important. If you want to maintain muscle health, bone health, you have to do every day, whatever it is. Aerobic exercises, not isometric exercises, isotonic exercises. That is very important. So looking all these, you have to maintain a healthy lifestyle, healthy diet, healthy environment, health wellness, health fitness and all. Everything is required. Thank you.
But Polnai has highlighted that don't wait for the fractures. Don't wait for the symptoms to develop. We have to preemptively identify it and prevent the progression. Once there is a fracture, once there is scoliosis or kyphosis, once there are bone pains, we have almost lost the plot. We need to pick up these patients much earlier, and that's where general practitioner and internal medicine comes into play. Usually osteoporosis is seen as an orthopedician's problem. It is not. It's a nightmare for the orthopedicians. It's a problem for the orthopedicians when there are fragile bones. It is for the general practitioners and internal medicine and other systems of medicine in the general practice to pick up these cases much early before they go into the porotic stage, before they get fractured. And in that, we have one important group, women. Women constitute a major group of patients where they disproportionately suffer because of osteoporosis. Dr. Jesse will be answering this particular question. Postmenopausal women as a high-risk group for osteoporosis, what are your thoughts? And what could be the cause and what are the usual symptoms of post-menopausal osteoporotic state?
Good morning, everybody, and especially the ladies in the crowd. Today, we are speaking about osteoporosis. It's very important, where it is not a disease which we can succumb to it and treat. We can avoid it. postmenopausal women, actually it starts from perimenopausal. It is postmenopause and menses, when it stops, it doesn't start. There is some period called perimenopausal. And at least 3 to 4 years before we stop menses, it starts the effect on the body. God has given us one varadan. Namge engasarige ondu boon kottidare. The thing is, we are given estrogen and progesterone, which is helping our heart and our bones. I think sometimes we are heartless because of that. Our heart is very strong. We see things and we avoid it because of that. And what happens in post-menopause is, there is a decreased bone density and deteriorating of the bone quality. That causes the increased risk of fracture. And this turnover is increased in early perimenopausal period in reducing the net bone mass. Simply saying that estrogen, when it is reduced, there is reduced bone density occurs in the bones, which makes that our bones very succumb for this osteoporosis. And ladies, they never walk slowly and gently. They are always in a hurry. You can see in your own house, because the husband will ask for the tie also with the wife, hanky also with the wife, Uta also with the wife, and children. Mama, where is my tiffin? Where are my books? Where are my scale? Where are my shoes? Even socks, everything they scream with the mothers. And they are never walking in a fragile way or careful. They are always on the run. They run here, they run there, and you can imagine, even with the grandmothers nowadays, grandchildren are more inclined to them. And if the grandmother is there, God has to help them with today's children. They are hyperactive and they are running, and they are more succumb for this osteoporosis. In the first 5 years, there is more than 10% loss of bone density in the perimenopausal time. There are 4 stages. In the first stage, what happens is, it just doesn't happen just overnight. Like how we have for pregnancy 9 months and 1 week for the pregnancy to fulfill and have a baby, same like this osteoporosis doesn't happen overnight. It happens, first stage, what happens is, there is increase of, as doctor said, there is bone density formation and decrease. So there is decrease and formation is in the same level. Second stage, mild decrease agtade, that formation and decrease. And third stage, there is decrease is there, and last stage, there is no improvement in the formation of bones at all, because there is no supplement given to the woman at all. They don't take, neither they have in their body. This is the last stage of the osteoporosis. Now symptoms. If as doctors have said, it always affects the spine. Now in our spine we have thoracic, we have lumbar, and we have sacral spine. If it is affected on the thoracic near the chest, what happens? There will be difficulty in the breathing. Then we will go to Dr. Chakrapani. Actually, Dr. Chakrapani, then he has to think about the bone, not only about the lung causes. So then he will run to our Dr. K.R. Kamath. Dr. K.R. Kamath will be thinking what happened. Then he will say, perimenopausal, okay, you hogli alli, gynec madam hatra. Then he will send them to me. Will you? Yes. So he will send them to me. Like that, if it is affected in the thoracic, they will have, so you have to think about a cause when they have difficulty in breathing, even the effect of osteoporosis in the thoracic spines. Then we come, there is a saying, the small child, in the end they become older people will become like a kid. There is a meaning in this. As they are growing, they stay peak age and they reduce even in their inches. If the spine is compressed, that time they will lose in their inches in their height. Then you have many people will have low back pain. The husband will say, "Salpa rest madamma, sari agtade, yenu illa." You rub some balm, Amritanjan, it stops. No. You have to send them for some checkup because their low back must be undergoing the osteoporosis condition. Earlier detected and given supplement, well taken care, they can avoid everything. And in the last way, there is a natural, many people you must have seen, older people, nowadays we see very rarely, they have almost 90-degree bending because their lumbar spine is affected. If their thoracic spines are affected, they are having gunbennu, the hunchback. So this is all because of postural osteoporosis is developing. We should succumb them for testing and supplement in time to avoid everything. Thank you.
Thank you, madam. Some of the risk factors are drug-induced. For example, anticonvulsant medications can produce osteoporosis. Anti-malignancy drugs can produce osteoporosis. It is very common to see after androgen deprivation procedures for prostatic cancer, or for that matter even breast cancer. But the most important aspect is steroid-induced osteoporosis. We give steroid for many conditions, but we forget to prevent osteoporosis. We just postpone the inevitable and not think about that inevitable. Dr. K. Kamath, steroid and osteoporosis, the problem of drug-induced osteoporosis. Can you explain that?
Thank you, sir. In fact, steroid-induced osteoporosis is the most cause for secondary osteoporosis, as the primary osteoporosis is senile and perimenopausal osteoporosis. That's the primary one. Secondary, as sir was listing the causes, the steroid is the important cause, and it is both duration and dose dependent. And also it is mainly due to the suppression of steroid will suppress the bone formation, and also rapidly it allows it to destroy. So that's the reason the steroid-induced osteoporosis becomes more prominent. It acts on osteoblast, osteocyte and osteoclast. And osteocyte and osteoblast, it decreases the formation, and on osteoclast will osteoclast will increase the resorption. Hence, the steroid will be the cause for osteoporosis. And it increases the fracture risk. If you are giving 15 mg per day, less than that, it increases by 5 to 9 per 1,000% fractures. Whereas it is more than 16, 3 times more when the steroid dose is more and more duration. And even if you stop the steroid, it will take 2 to 6 months to decrease the incidence of fractures. So it is more important that when we are giving, as sir was telling, giving steroid also maybe steroid is necessary for that condition, also take care of the bone health and supplement with the required bone minerals. Thank you.
Dr. Purnaya, there are many medical conditions which are associated with the osteoporosis. The knowledge is important because whenever these medical conditions are there, proactively look and search for osteoporosis. Can you elaborate on that?
Thank you. There are so many medical conditions wherein osteoporosis occurs, especially hormonal disorders, medical conditions, either menopausal. It is really surprising, being a dominant sex, why women suffer more fractures. It's really surprising. Is it the positive effect of testosterone for men, or the sudden stoppage in menopause, estrogen influence? No. So one thing is, main important is medical conditions, hormonal disorders. Second, absorption, calcium supplementation, absorption, gastrointestinal disorders, anything, chronic, lower intestine, lower ileum, it affects the absorption of calcium. Even though if you supply gastrointestinal disorders, one more, anorexia nervosa is also one more thing. So there are so many, you can say, medical conditions like rheumatic arthritis. That also affects the lifestyle. It also causes one of the main causes, rheumatic arthritis. And you can list so many medical conditions wherein every medical disorder, organ damage, renal rickets, we say, renal cause, hepatic cause, lungs, cardiac cause, anything can cause osteoporosis, medical conditions.
And not forget thyrotoxicosis also, that also can produce osteoporosis. Dr. K.R. Kamath, we have understood the pathophysiology of osteoporosis. We have gone through symptomatology, but how do you diagnose this condition? Can you diagnose with plain X-ray, or does it require sophisticated infections? Are there any blood biomarkers for osteoporosis? What, Dr. Kamath?
Thank you, sir. So diagnosis of osteoporosis never taken as a primary osteoporosis without ruling out other secondary causes. Actually, the good history and physical examination of the patient is almost an important part. As Madam was telling, as the patient enters inside also, we can be able to find out that osteoporosis she is suffering from the osteoporosis. But certain laboratory tests like calcium, phosphorus, alkaline phosphatase, vitamin D estimation, and PTH may be required to rule out other conditions. But usually one X-ray, if you do even with the X-ray, spine X-ray or pelvis with both hips X-ray can also confirm the diagnosis of osteoporosis. And most of the time, we do this investigation to rule out other conditions, namely few of them like if in calcium, phosphorus, alkaline phosphatase may be abnormal in osteomalacia and hyperparathyroidism, hypothyroidism, and ESR and serum electrophoresis may diagnose the multiple myeloma, and increase in the homocysteine will tell the patient is at high risk for osteoporotic fractures, fragility fractures, and maybe to prevent or sometimes to confirm conditions like condition of osteoporosis, the BMD is the best one if you have to convert. This is BMD is a dual energy X-ray absorptiometry scan. It is like a CT scan machine. It is not available all the places, even though, and it's a radiation method which X-ray hazard is there, radiation hazard is there, and this is a machine will tell means actually what is the amount of osteoporosis, and we can give the classification also. And this will be costly. In fact, it will cost about 3,000 to 4,000 rupees. And in Mangalore, there are only 2 or 3 places it is available. But most of the people confuse it for the BMD done by the ultrasonogram. This is a common one. This is a machine, maybe 50 lakh BMD machine with investment is about 50 lakh rupees. Next. And this is a commonly done. BMD scans we do in clinics, camps, everywhere. And where we find out, it's a ultrasound technique where the speed of the sound is estimated in the calcaneum, in the tibia, or in the wrist. The speed of the sound is estimated, and you get a rough estimation of osteoporosis, whether the bone is normal, osteopenia, or osteoporosis with this machine. And commonly it's an ultrasound guided one, usually available. And we do this T-score, that is -1 to +1 is normal bone density, and -1 to -2.5 is osteopenia, and osteoporosis more than 2.5. People get the value 3, 4, 5 like that, and such people are prone for fractures. And T-score more than 3, they require not only vitamin and calcium, they also require other modalities of treatment. And one more thing is, now we have to, because this is a World Osteoporosis Day, we need to not only doing BMD scan, also people should be educated to find out what is the chances of they getting fracture. So fragility risk assessment model is available. These apps are available on the net also, where you find out the age of the patient, gender of the patient, any previous illnesses, previous fractures. You can assess the risk of that person having the fractures. Slowly this should give more importance so that people know about osteoporosis and also what is the chance of they getting a fracture. In Europe, the BMD scans are done at the household, on the street, that is with the DEXA scans. And we are now in India doing bone scans. And people do ask, the middle class, the bank employees, the teachers ask us, when is the BMD camp next you are doing? So that's a good awareness, not sufficient, maybe 5% of the population we are reaching. We have to increase that so that every person knows about this, at least the BMD done by ultrascore sonograph, and people will know about their score and try to get a treatment and also be cautious, aware, and tell others about the osteoporosis and the fragility fractures.
You can use this clinical scoring in your clinic using your mobile and scientifically decide who requires next evaluation for osteoporosis. And ultrasound is just a screening method, not a confirmatory method. Confirmation by, as Dr. Kamath has pointed out, DEXA is the only confirmatory test for osteoporosis. X-rays are very, very unreliable. They will tell you only when there is advanced osteoporosis. If you want to pick up early osteoporosis, if you want to prevent the fragility of the bones, pick it up early by all these screening tool, then going for DEXA scan. Dr. Polnaya, prevention is much more important. Should we wait for the confirmation to initiate preventive measures in the field of osteoporosis?
Of course, prevention, there are two issues, prevention and promotion. Prevention is one aspect where treatment intervention, it is medical. Promotive regard to the lifestyle. So preventive aspect, you have to see that adequate supplementation of calcium and vitamin D. That is important. That also especially who are susceptible for osteoporosis. One thing that is the most important, that can be done by calcium and vitamin D supplementation or green vegetables which supply calcium, iron and all, and avoiding smoking, alcohol. These are all very important. These are all, as I said earlier, all modifiable factors. So prevention is only, if you take care of these, you can prevent, certainly.
Thank you, Dr. Polnaya. Dr. Jesse, what is the role of hormone replacement therapy in preventing and treating osteoporosis?
Since we are told the main cause of osteoporosis in women is decreased estrogen level, it is not the drug of choice for the osteoporosis treatment. It is just all covered by the insurance, medical insurance, where in our Indian system we have to shell out from the pocket. By the time many of the women reach perimenopausal, if they are homemakers, there is a crunch of finance that time because all their children are in the higher education level that time. Very rarely children are reached that time for the earning. So they can support the family or anything, it matters. So among Indian women, they very rarely go for this HRT. There is a lot of myth about HRT. And the thing is, even when we are giving HRT, we have to do certain investigations of the women in other systems because HRT can have other contraindicative problems in the women. So taking all the factors, people are not aware, and definitely this estrogen supplement and HRT does have a role, but the main drug of choice is the Fosamax, that is bisphosphonates. It 75 milligrams, which is given as a weekly pill with the supplement of estrogen. One more thing I want to tell you was, many people we give as the perimenopausal calcium, and we give D3 once a week, vitamin D. If you give only vitamin D, I have seen it doesn't help the woman. You have to see to it they take with the calcium, isn't it, doctor? With the calcium, if you give the vitamin D3, only it helps the body for absorption, and both these go in hand. It is vitamin D is different and calcium is different. Both together, if the supplement is given, they go two chakras of a bandi. If one goes, another one will get stuck if you give only one. So both, if you give only that, your rath will move smoothly. So remember always, whenever you are supplementing vitamin D3, please supplement with them with calcium also. And another thing is, growing up children, please give them a glass of milk, our age-old therapy, up to their 13 to 15 years, which will help them in their old age. Please give them up to 15 years a glass of milk in the morning, glass of milk in the night. Because we were supplemented in our house. My mother had kept a cow in our house just to feed us. We were 6 siblings. And a glass of a big, that beer jar, 1 glass morning, 1 glass in the night, we had to drink because my mother used to sit with the Nagar Betta with us. Drink that, all of us. All the 6 mugs were there on the table. And that has helped my bones today. Even if I have a fall, I jump back.
Resilient bones.
Yeah. It is very important.
Importance of hormone replacement therapy and also need for calcium and vitamin D supplementation together. And Dr. Polnaya also has already highlighted the role of calcium and vitamin D. Now, final question to Dr. K.R. Kamath. Yes, we have thought about osteoporosis, discussed the pathophysiology, identified it, and then investigated it. How do you treat it?
So, thank you, sir. And these points have been touched already by Madam and Polnaya, sir. And HRT she has discussed. And calcitonin and bisphosphonate are the other important group of medications. The mechanism of action of bisphosphonates is it binds to surface of the hydroxyapatite crystals and inhibits resorption. Mainly they work on the osteoclast. And the side effects are one of the things that we have to always tell the patient to take this medication empty stomach and not to lie down immediately. They are asked to move around a little bit so that they will not get that reflex esophagitis. And Madam has already told about these medications, relaxapine. And calcitonin is the other one, that is a nasal spray that is being given. It mainly decreases the bone pain and not much role in the prevention of the osteoporosis. And also we are using fluoride, and now the teriparatide is in a big vogue. We are using teriparatide for decreasing the bone resorption, always increase the bone formation. And these are the things. And also we give denosumab, that is one more drug that is given once in 6 months. And now the one more newer version, remusumab, also has come. And this also will be increasing the bone formation and decrease the bone resorption. And we have discussed about the exercises and the posture, and also what are the ways to decrease the pain and increase the activity of the person. And next. The one important thing is, in spite of all these things, the prevention is very important role, and we have to need to educate the young women and teenagers. And in spite of this, the 5 countries, the last year survey says, in spite of all this, 43% of the women more than 60 years of age get fracture. Almost every second person after 60 years gets a fracture. And 45% of people don't get calcium vitamins in spite of having fracture. So we are, the orthopedic surgeons, we do operation. At the end, we don't do proper maintaining the calcium, vitamins and other required. So they come after 1 year with one more fracture. The right side hip fractured last year, and the left side one more time in 1 year is not at all acceptable. So in this case, the general practitioners whom the patient would have come after a follow-up of the patient had a fracture, started walking, and next he may come with the general practitioners for diabetes, BP. That time also see that these people do get calcium, vitamins and anti-resorptive therapy so that they will not get fracture again. Otherwise, every second person gets operated by me should not get a fracture. That is an important message. As an orthopedician, I would like to take.
Thank you, Dr. K.R. Kamath. It was a very fascinating discussion. 3 facets of the disease discussed by 3 people in their own field, and we have seen the gamut of osteoporosis and the relevance in the primary care. I thank IMA for thinking about this topic and calling us for discussing this very important and fascinating topic. Thanks to chairpersons for keeping up the time. Thank you very much.
Thank you. Thank you, sir, for the opportunity.
Thanks, everybody. Just a moment. Because nobody likes the spineless fellows, but everybody likes the boneless chicken. So, there is a summation. We all have done well, sir, on time. Thanks a lot.
Is there any
Small comment.
interaction?
No, Dr. Paulay has been always a fighter with me because of updates. Who has passed his American examination, still rotting in Ullala Sankadache, USA. So he's subject-wise. Thanks a lot, everybody. Comment from Dr.
Good morning, everyone. My compliments and congratulations to the IMA organizers for the wonderful IMA CGP conference. And I would like to thank Annaya Kulal sir for the opportunity given me for as a co-chairperson on the occasion of Osteoporosis Day. And the mantra here is lifestyle change. We have to tell our youngsters to follow the good diet rich in calcium and vitamin D. Prevention is always better than cure. So that we can follow, fit at 40 and strong at 60 and independent at 80. That should be our mantra. Thank you, everyone. And it was a good session and a wonderful panelists.
Moment of joy, a keynote to Dr. Jesse actually. All when we were women were active, you also look for hyperactive men. Right. That's a memento by FDA, IMA, all. To Dr. Jesse. And to Dr. Chakrapani. Dr. K.R. Kamath. Good. And now comes Dr. Sadashiv Paulnaya.